Practitioners. It is brought to you by the CFHA Research and Evaluation SIG, so we're very thankful for those folks and pleased to have our esteemed speakers today. Just a bit of housekeeping. As we're going through the presentation, if you do have questions, feel free to type those on your navigation panel on the right-hand side of your screen. There's a box with which you can type in any questions. You should have all received a packet of handouts in your email in the last couple of days. The faculty today will be referring to those handouts. We will be recording this webinar, and it will be up on the CFHA website within the next few days. And the faculty has also agreed to provide a copy of the slide deck for those of you who are interested in that. So we'll be sending that out after the broadcast today. So let me just very briefly again welcome and introduce our speakers. First of all, I'd like to introduce Dr. Patty Robinson. She's currently the Director of Training and Program Evaluation for Mountain View Consulting Group. This company was founded in 1998 and won the APA Presidential Innovative Practice Award in 2009. She has many projects including consulting, training, and writing. She provides training in primary care behavioral health and focused acceptance and commitment therapy all over the world. She is committed to healthcare transformation and to improving care to all patients, particularly the medically underserved. Her interests also include prevention science and the use of contextual behavioral science and principles of pro-social group design to enhance clinician resiliency and primary care team effectiveness. Our second speaker is Dr. Heidi Csha. She's a licensed psychologist and has done work pioneering work in the medical home model, working with both at-risk adults and children in diverse urban settings in Portland, Oregon. Dr. Csha studied at Northwestern University, where she received a Master's of Science in Marital and Family Therapy. She earned a doctorate in psychology from Alliant International University and did her doctoral fellowship at UC Davis Medical School. She was possibly the first person who was blind to be on faculty at the medical school, Oregon Health and Science University, and as a pioneer has been a strong advocate for inclusion for many underrepresented populations. And finally, Dr. Javier Nuna is a licensed psychologist and the Director of Integrated Health Services at a federally qualified health center in Winters, California. There, he has implemented and sustained a successful model of integrated behavioral health and health coaching into primary care since 2012. With a population health focus, the integration model has continuously achieved a wide in-reach into the general clinic population, assisting primary care providers and allowing greater success for patients to receive help for behavioral health conditions. Dr. Luna received his PhD from Seattle Pacific University in 2010. So welcome to all of you, and Patty, I'll turn the webinar over to you.
Okay, thanks very much, Polly. It's a real pleasure to be here, and I just want to give a shout out to Collaborative Family Health Association for sponsoring a mentor-mentee training program that gave me the chance to work with Heidi and Javier over the past year, and also to the Research and Evaluation SIG for supporting us and kind of sharing what our experience has been about. So kind of the way of bringing this together was to kind of frame our talk today in terms of thinking about being a scientist practitioner and challenging everyone to integrate program evaluation into their clinical services, into their work in their clinics. So today, we're going to talk just for a few minutes about features of the scientific practitioner approach, and then we're going to talk about Heidi's and Javier's experience in being scientist practitioners in their primary care clinics. And I think it would be pretty interesting because Heidi's in a great big system in a big clinic, and Javier's in a rural setting in a small clinic. So I think that will give us some diversity and interest We're going to talk about their project, kind of what their research questions, concerns were, and discuss their results. And we also want to share some of the tools that they've used in their work. So the scientist-practitioner model is an approach to practice that asks the clinician to allow empirical research to influence their applied practice. And of course, we all want to do that. We always are using evidence-based interventions, but it goes further than that. It really goes to, well, in using these interventions, what are the results? And what are the barriers to dissemination of these? So lots of interesting questions come up when you put on your scientist-practitioner glasses. Also, a feature of this model is looking at the results of your assessments, your ongoing assessments, and using those results to shape future research questions. This is an approach that continually advances science in our field of primary care behavioral health and is often, I think, providing us with the highly relevant findings that we need to move forward with confidence and with creativity. So what we're going to do today is look at scientific information suggesting a primary care behavioral approach and identifying discrepancies between defining features of this model, the primary care behavioral health model, and current practices at the clinic level. So Heidi will be talking about that. And then adjustments in practice to address these discrepancies or these gaps and the impact of making these changes on outcomes of interest. Heidi will also probably talk a little bit about opportunities to advance PCBH work, and Javier for sure will be talking about primary care clinician, PCC stress, and service to high impact groups. So different ways of advancing or evolving the model. So with that, I would like to turn this over to Heidi, and she'll talk with you about her experience at the Providence Gateway Clinic.
Great. Thanks, Patty. So I work in a large family medicine clinic. We have about 22 providers. And when I started there 5 years ago, back in 2011, I was the only BHC in the whole clinic. So I'll leave that to all of your imaginations in terms of what that was like and how integrated one person can be in such a large clinic, which in our case was not very integrated. And so we had the pleasure back in 2015 of having Dr. Patty Robinson come and do some training with me and helping me to sort of figure out, number one, how to better integrate myself in such a large clinic and what were the things that we needed to do and how do we assess our success in that process and sort of what goals did we need to set and how do we know we actually achieved them. So today I'm going to talk a little bit with you about that process and the kinds of things that we had to look at and the questions that we asked and the process that we've been going through to come up with some better alternatives. So the tool that I want to talk about today, which I believe you all got sent, was the Behavioral Health Integration Tool. And this was a great tool that we used and emailed to providers back in January of 2015 to start this process. And what we wanted to find out was where were the gaps in integration and how could we overcome those gaps. And so we needed a way to quantify that. And being a hardcore clinician, I got pretty scared of the idea of program evaluation and lots of numbers. And so Patty assured me that this was all going to be simpler than I thought. So, and it has been really interesting and kind of fun to see how we got to where we are today on paper. It makes it a lot more real. So I'm going to show that to you all today and talk a little bit. Patty and I are going to do sort of a back and forth process with this, showing you the data and sort of replicate a little bit of the conversations that we would have through this process of going back and forth.
Okay, so this is over a 15-month period, and we decided to present the data in a way that you'll get an idea about the key items on this tool. There's actually 53 items, and we're just going to...
We're not doing all of them.
That's right, because some of them were actually yeses from the beginning.
Yes, right.
Yeah,
yep.
But some are still no's.
Some are still no's, yes, that's true.
But we're going to go over the 14 that leadership really bought into at the clinic level and moved them from no to yes, and that resulted in improvements to key outcomes.
Definitely, yeah.
So the first has to do with that same-day service. So I recall 15 months ago, less than 40% of the behavioral health visits were provided on the same day.
Yeah, it was definitely sort of a lofty goal at that point that we would get to 40%, I think, especially given the amount of providers we had, the size of our clinic, and that there was only one of me at the time. We really just couldn't physically make those same-day visits happen. And now I'd say we're up to around 60% of our visits during the day being same-day visits. Every single one of our providers have really bought into the fact that it decreases our no-show rate. We can meet patients where they are in the moment. I think we have a lot more buy-in to trying to get us in those visits on the same day. So I think we're continuing to improve, but it's been really fun to see that change.
Okay, the next one, do PCCs believe that in-clinic behavioral health provider staffing level is adequate?
Yeah, that was, as I've mentioned, woefully inadequate before. That has shifted. Now we have 2 of us, which, we've doubled our staffing. And it's been amazing what a difference it's made. We've been able to sort of divide up the providers that we each are responsible to and can help, and that's made a big difference. We can easily do those same-day visits together now.
And the third evaluation point has to do with communication. So does the BHP or behavioral health provider have a pager or cell phone so that she can be reached immediately by the PCC?
Yeah, and we didn't have that either. I was running around the clinic like a crazy person, and Patty can tell you I was getting my steps in for sure. But so were providers, and I think they were a lot less likely to call us because it was yet more time out of their day. So we do have cell phones now, and we have an instant messaging way for providers to get us. And so that's made a big difference, and they're a lot more likely to utilize it as well. So we have improved in that regard for sure.
And the PCCs now have established protocols for contacting.
They do, yes, they do, and that was the next one of these items. So they know they can use the cell phone or this instant messaging system that we have on their computers right away, and they don't even have to do anything. They just either pick up the phone or they're already on their computers in their electronic medical records. They can get us right away. So I think we've simplified that for us and for them.
Okay, and moving, I don't know, I've lost, okay, there we go. All right, so does the BHP design in place exam or waiting room posters? That's another important item, communicating with providers and patients.
Yeah, and it's interesting. I had never even really thought about this as being a really important aspect, but I'm amazed at how often I get patients who come to me and say, hey, I saw that poster you just put up about what is trauma, and I saw the posters about smoking cessation and the advertisements you have up about the groups. I'm interested. Can you tell me more about it? So that's been really fun because I was a little bit skeptical about how much of a difference is this really going to make. But we have started to do that. In fact, my assistant and I sit down once a week and we change out the posters and we think about what sort of the next push is for communication in that regard because it's been so effective.
Excellent.
Yeah.
And how about speaking routinely, the BHP speaking routinely?
Yeah, we do. My colleague and I sort of switch off doing that. So when I first started at this clinic as the only BHC, I think I could count on my right hand how often I was speaking at provider meetings. It was just kind of one of the things, they were always so busy and so full that I kind of felt like, gosh, I don't know if I'm going to find a space for this. And now, having talked with the medical director and I think really seeing the importance of FaceTime with providers, this is another way to get out there and be on their radars on a consistent basis. So I get at least 5 minutes every meeting, which doesn't sound like a lot of time, but it's a lot better than nothing. And there's a lot we can get done in 5 minutes, even if it's just, hey, can you tell me, how the referrals are going or what's working or what's not working, that kind of thing. And then sometimes we'll have specific presentations on behavioral health interventions. What are we doing for insomnia, for example? I did one just a couple of months ago on behavioral health interventions for sleep issues, and we talked about that so that providers know if I'm referring for insomnia, this is what's going to happen. So that's been working really well.
Okay, and then number 7 gets at the idea of just making BHP service more routine. So are BHPs involved on a same-day basis when adult or child wellness visits result in detection of a concern?
Yeah, and we definitely are more now. I would say this has become a yes, but it's sort of a yes and.
Okay.
It's definitely a work in progress. I think we are more integrated into wellness visits, but I really feel like this is one of our big growing edges right now. I do get called to talk with families about things like positive MChat screeners, which is our screening for autism with young children. Hey, we got a positive screener. I've talked to the family, but they might want some extra support or to talk about the difference between screening and diagnosis and things like that. Then I might pop in and do that for a few minutes to spend some time with these families. But I think this is something that will continue to grow as a yes.
And probably something from a scientific practitioner point of view that you could explore more, looking at data, looking at the rate of involvement of BHPs in, say, a specific visit like the adolescent child visit.
Definitely, and I'm open to ideas and thoughts about that too, just other ways that other folks have been able to integrate themselves into these wellness visits would be really helpful.
Okay, number 8, does the BHP use a standard assessment measure at the beginning of consults with children and youth?
We do. We did not start doing that again. We had no screeners for kids, actually. For anyone under 18, we weren't doing any screeners, which was amazing to me. And now for teens, we have the CRAFT, which is part of our ESPERT project that we're screening teens. And then we use the pediatric checklist, symptom checklist for kiddos. And it's been fun for me to see parents' interest in these screeners and kind of, at least for the kiddos, they don't get to see the teen ones, but for kids, it's been really nice for them to kind of say, wow, it looks like their numbers are improving. I wonder what's making these changes, and to kind of get their buy-in for the symptoms for their kids as well. So we are using routine screeners now. When patients come in with their families to the front desk of the clinic, they just get the screener to fill out as a matter of course.
And number 9, are patients routinely referred to the BHP for assistance with developing healthy lifestyle behaviors?
So I used to call myself the integrated mental health provider because all of our referrals were really around depression, anxiety, mood disorders, things like that, which, is one piece of the puzzle, but there was so much untapped need in our clinic for these healthy lifestyle interventions, motivational interviewing to help with diabetes and hypertension and obesity. So that was one of the things I started to talk with providers about in the meetings that we had. Hey, this is something I can help you with. Or I would do a lot of chart scrubbing ahead of time. That was a huge change. Once I started seeing what patients were coming in for, I would put little notes in their appointment schedule so they could see BHI, behavioral health question mark, like I'm here, hello, think about me for this patient who's coming up to follow up on their labs. So that has slowly shifted, and we now really get a lot. I think all the referrals I had yesterday were around diabetes and obesity. So it's shifted in a really good way, I think.
Related is number 10, do PCCs use biomedical markers to trigger referrals?
So we're starting to do that. We have an A1C marker right now of anyone over an A1C of 9. And a lot of times what we've been able to capitalize on in this regard is, providers are evaluated on these biomedical markers, and they're a lot of times get bonused accordingly. And so I try to leverage that with my folks, like, hey, this is something I can help you with. I can help you with those A1Cs of 9 or above, and let's work together to try to lower those because it benefits everybody. And so those are just ways to kind of think about leveraging your providers in other ways as well.
And number 11, does the clinic have one or more pathways involving use of behavioral health services concerning health risk behaviors?
We do, and this continues to be another one of our growing edges. We have a chronic pain pathway right now where we get folks in, and I think we'll mention groups in a little bit, but we are trying to get everybody, again, for that A1C of 9 is another pathway, and smoking cessation. So anyone that says yes to do smoke tobacco is a referral to us just to kind of see, hey, where are you in that process of quitting? Have you thought about it? It's not necessarily like you need to see me for sure, but I just want to check in with you. I'm a part of your care team. Tell me how things are going.
Excellent. Number 12, does the clinic have one or more pathways involving use of behavioral health services concerning chronic disease?
So, and I mentioned that with our diabetes A1C of 9 pathway as an example of that. But again, I think this is a growing edge for us. I have a lot of ideas for other pathways and would love to hear other folks' ideas about that as well.
Yeah, I think the pathways are just a wonderful way of making our services just part of normal routine. Yeah. Just a part of good health care.
Right.
Number 13, does the clinic administrator provide the BHP with productivity data on a monthly basis?
So this is something that we weren't doing for a while. We knew we were not as productive as we could be, but we didn't know how much we were not productive. And now we have access to monthly reports. They're on a SharePoint site that we can access at any time. So anytime I can sit down and say, hey, I wonder how June was, and where were we, and what were the types of referrals that we were getting, and what's working and what's not working. So we can kind of self-assess that now, which has been really nice.
And number 14, do PCCs receive feedback on number of referrals to BHPs?
This has been kind of fun. They do now. They didn't for a while, and I had no idea how fun it would be to leverage their inner competitiveness, but I now have a PCC that every month will come to me and say, hey, Heidi, am I number 1 now? Have I made the most referrals, And so she was somebody that was maybe referring 1 or 2 patients a month to her, and now I'm seeing 16 to 18 referrals a month from her. So huge differences just because she likes to just pretend but that she wants to be first. But it's also made a big difference, I think, for her to actually see the progress her patients are making. So it's a win-win. But it has been fun to sort of make a game out of it.
All right. So with 14 no's moving to yes, the impact has been really good.
It's been really fun to see the changes in our clinic. We've got a ways to go, and we're still working on a lot of things, but it's been nice for me to see the progress, because I think without that you kind of get discouraged or think, gosh, I wonder if we're making any changes. And so that's been the real benefit for me of actually seeing the numbers and how this has worked. So thank you for actually making me crunch numbers.
Good.
Yeah.
Good. And more diversity in behavioral health services. Now you have some groups.
Oh, yeah. We have just started doing a few groups. I mentioned the chronic pain group. We have a group for new moms, and that's been a really fun group. I call it Monday Moms because we meet on Mondays. And we start with moms that are around 12 weeks gestation through about 6 months postpartum who are a part of this group. And the goal is really to capitalize on this time where moms can feel pretty isolated and might need some extra support, and also through postpartum issues and prenatal issues around mood, family concerns, things like that. So that's been really fun for me and pretty gratifying. And then we have a group for people with different disabilities, and so the diversity of that group has been really fun. We have some folks with rheumatoid arthritis, we have some folks who occupy wheelchairs, we have a couple of people who have visual impairments, one person who has a hearing impairment, so lots of different needs in the group, but lots of strengths, and everyone kind of gets to see how people move in the world as folks with disabilities. So that's been really fun for me to be a witness to. So we've got a real diversity in our groups now as well.
Awesome. So seeing a lot more of the patient population, greater penetration and satisfaction surveys with the PCCs
yes,
are looking very
they're
good.
looking better. Yeah, I think PCCs are seeing the benefits of having the groups, seeing more patients than we were before, and really more opportunities for them to get folks plugged into some resources that didn't exist before.
Awesome.
Yeah.
So with that, I'm looking at the time. It's 10:33. I think what we'll do is we'll just go ahead and move to Javier,
Perfect.
and then we'll take a lot of questions at the end. Does that sound
Great.
good?
Yeah.
Okay.
Thanks.
So, Polly, you can go ahead and give Javier the screen if you will. Thank you.
Okay, so hopefully you guys can see the first slide there, which says Winners Healthcare. Yeah, if there's any issues with it, just let me know, but I'll just assume that's a yes here. My name is Javier, and as Polly mentioned, I work at a smaller clinic in Northern California, and we're about 60 miles about east of San Francisco, and then about 35 miles west of Sacramento. So we're a small FQHC, probably compared to most other FQHCs out there. We're kind of a rare health center in the sense that we're still a standalone clinic and serving our small community of Winters. And we've had we've had PCBH services since October of 2012. That's when I started the program, and there was some semblance of an integration program before then, but when I took over in 2012, took a few months, but we started implementing PCBH services, and which was doable because it was a smaller clinic and able to, it was a little bit easier operationally to implement the model. We also started a health coaching program, and this was kind of just necessarily wasn't by design, but we just had a kind of a health educator who was working, and just saw the opportunity to bring her along, and she became kind of a hybrid. She's a health educator, but she became more of a health coach and working kind of like a BHC. I took a little bit of the model from UC San Francisco and their health coaching model and kind of blended them together, and we started our health coaching program, and now we have 2 health coaches who are working in our clinic. We have about 3 or 4 primary care providers in our clinic, so again, we're a really small clinic. 2 of our providers are full-time, and then 2 of them are one of them is part-time, the other one is just a few hours a week. And our goal for this was just to have a more comprehensive program evaluation. We had our previous kind of program evaluation, or my program evaluation efforts, had kind of focused more on process measures, in-reach, more handoffs versus scheduled patients, and we actually were doing really well, and all of those by comparison standards were really well compared to what you would want to expect in a PCBH model. So we had a lot of same-day appointments, a lot of in-reach. We're seeing about a quarter of the whole population, so we were doing really well. And our goal, or my work with Patty, really, our objective was really to have a more comprehensive kind of program evaluation and include kind of provider satisfaction, some stress, and also some of the needs, other needs that are going on, high impact groups, so, patient populations that are challenging, again, in stress, and then satisfaction. So our, this was I think this was the second time I had done a satisfaction survey. This was a little bit more formal. We had I think you guys should have a copy of this satisfaction survey. There was about 10 questions, and these are just two of the questions that that were included in that overall satisfaction survey. And all things considered, how satisfied are you with having BHC service in your clinic? And pretty much everybody was pretty satisfied. And so sometimes at a smaller clinic, you can kind of get the gauge of gauge of their satisfaction just because you're interacting with just a few people on a regular basis. But it's still nice to get that data and get that information from your providers that they're satisfied, and even some room for improvement, right? Moving those two very satisfied to completely satisfied. So it gives you something kind of to work to. Obviously, our providers were very thankful that I'm in the clinic, and so that was nice to see. Definitely, the fact that they wanted us in the clinic and that they would recommend this to another colleague. So that was nice to see. But pretty much all of the satisfaction surveys questions were pretty good, pretty positive. So going to provider stress, and so I also gave them the provider stress checklist, and this is a questionnaire that also should be available, and it's so the higher the score, so it's between 0 and 100, so 100 would equal more stress, 0 would equal less stress, and so we had four of our current primary care providers complete the survey, and it was, you can see there, some outliers there, but for the most part, I mean, pretty consistent there as far as what areas tend to contribute to the most stress for the providers. Go on to the next slide here, and so there was one of the outliers was education for one of the providers, and then the other one was one of our primary care providers, which I have a pretty good idea who it was because she works very few hours a week and is pretty much retired, and so I can see, if I go back to this other slide here, didn't really have a lot of stress, or didn't really had a lot less stress overall, but didn't really struggle with work-life balance. But the rest of them were pretty consistent, and the two areas that were the most stressful were patient interactions and also kind of practice management things. And one of the things that came from this, and my work with Patty, was to actually be a little bit more, how I say it, to talk to the medical director about this and to actually schedule a meeting with our providers. And we had a provider meeting a few years ago, and it was kind of something we're doing on an ongoing basis. But then it just kind of, other things got more important, or we started kind of moving towards a clinical staff meeting. But one of the things that came from this was just the importance of actually meeting with all our primary care providers along with our behavioral health clinicians. And one of the things that we're going to be doing, actually starting this month, is actually having a provider-only meeting. It's going to be at lunch. And one of the things that we're going to do is just to kind of, brainstorm some ways to address some of the stress, and perhaps even kind of asking some more specific questions about, what exactly is it about those patient interactions that contribute to the most stress. Also, asking about, is there specific patient populations that contribute to more stress? And so that's kind of the things that we have planned, that I have planned, and I'm also working with our medical director to, get something going on a regular basis where we can talk about stress and specifically what kinds of patient interactions or patient populations are actually contributing to that stress. Another survey that I gave was a high-impact survey, and so this is meant to ask the primary care providers, what areas of priority, what specific patient populations do they see as really requiring a behavioral health consultant or BHC? What are the populations that they really want us involved in? And this was the results of the survey. Nothing was surprising about the first group there, but depression, chronic pain, anxiety, domestic violence, even the middle high, family, parenting, alcohol, and ADHD. And the medium low was interesting, and we had diabetes and overweight. And one of the things that I realized, or what this led me to kind of realize with our health coaches, and we have 2 health coaches, and they've taken over a lot of the diabetes visits and the obesity, overweight kind of referral questions, and they've done a great job. And a lot of the times I've actually, in order to help them kind of feel a bit of the team, they often get the first sort of crack at a patient with diabetes or with obesity or a child that's overweight. And so they're getting the majority of those referrals from our primary care providers. And it's been a great success. Our primary care providers just automatically see them as a part of the team. One of the things that I realized from this survey was just the importance of kind of clarifying exactly when does a patient or a child or a diabetic patient need how do you include a behavioral health consultant in that care, right? And so this idea of a step care approach, where making it very clear to the health coaches and to the providers about when would it require a higher level of care, more than just sort of your routine. And so that's something that I've done with our providers and with our health coaches, so that they begin to understand when they need to refer back to the behavioral health provider, which and their supervisor, which is myself. And so I think a lot of times, and maybe a lot of behavioral health people can relate to this, but when you're the last one to be, when you're the one getting referred the patient, so you're constantly kind of asking, trying to get into more referrals and more problems. It's oftentimes I realize that sometimes the health coaches, or even when you're the last sort of step in the clinic, sometimes we have a harder time kind of referring to other colleagues. And so, working with our health coaches to actually learn how to refer patients back to us in a different direction is something that I've learned is actually really important. And they actually have to be trained. Again, it's easy to sort of want to be involved in a lot of, get more ambitious about taking on more patient problems, but it also requires a little bit of skill and the language you use to refer back to, to a behavioral health provider as a health coach. And so that's one of the things that we've done. Another thing that we've done is sort of been more intentional about parenting questions. Sometimes these can be left out of a well-child visit. I mean, there's so much going on during a well-child visit, and so one of the things that we've done is kind of, just make it more systematic, that we're going to ask parenting questions during the well-child visit. And I actually found a lot of parents are actually pretty open talking about this, and a lot of times it could just be a matter of giving them a handout or a suggestion or some kind of advice that may help them to address maybe behavioral problems better in their children. And also the chronic pain. I mean, I think that one of the things that chronic pain is it's a big area of stress for a lot of primary care providers, and so one of the things that just seeing chronic pain on there wasn't a surprise for as far as our involvement. I'm already involved in a lot of our chronic pain patients. We do a pretty decent job, I guess, in providing comprehensive services to them. But one of the things that it did, this survey did result in was just kind of updating our medication agreement. We actually use the word medication agreement just because we want to. Our clinic is small, and so we wanted to, use it for also patients that are using benzos and sleeping pills, ADHD medication. So we use the term kind of medication agreement here. And one of the things that we did recently was just renew it and kind of update the language a little bit. And also what we did was kind of more of an emphasis on functional goals. And that's something that really struck well with the providers, who oftentimes, again, have a hard time kind of measuring progress with patients with chronic pain. But one of the things that we've done recently is kind of, as patients are coming in, chronic pain patients, we're kind of updating the medication agreement and kind of, it's kind of giving us an opportunity to have a discussion about functional goals, and which I think will bode well for the future and future visits with their primary care providers. So let me go to the next slide. So future program evaluations, I mean, there's obviously so much that you can address in the future. Definitely, what is our role in addressing stress, right? I mean, I think that as primary care providers, we have a lot of ideas, we have a lot of tools, and so looking at stress and how do we address it, right? We can address it systematically, we can address it sort of clinically in a sense, in helping providers learn tools to manage stress, and so that's some of the kind of future, questions that people could, you could address or explore. And then, Patty, you could talk about this other one about just, exploring our role in education, right? I mean, I think that, one of the things that I've learned in my short time here in the clinic, is that the medical model is a very powerful model in the sense of it's been kind of the the way of going about things for primary care providers, and so with that comes a lot of stress and feeling like they have to solve every problem, and so a lot of times we may consider how exactly we can change that. What is our role in changing the way that primary care providers do their work, right? And so that's some future questions that we could kind of explore there. So.
Right.
So that,
yeah, just coming in on that, Javier, I think that it's kind of a new role for many primary care behavioral health providers to be teachers, and yet it's an important role because many primary care clinicians were not trained in behavior change interventions as a part of their medical training. So they may have had some exposure to family therapy, maybe training in motivational interviewing, some certainly health education as a part of their behavioral medicine. But there's a lot of very helpful cognitive behavioral and contextual behavioral science interventions that primary care behavioral health providers can teach really to their primary care and nursing colleagues. And we can do that in so many ways. And as they learn to do more things, I think, the medication culture that's kind of developed in the absence of behavioral health providers will start to shift, and that level of stress that you're identifying from the survey in regards to interacting with patients will come down. I know over the course of 5 years with the chronic pain pathway, when I was working for Yakima Valley Farm Workers Clinic, I could see changes in the way that primary care clinicians answered our survey about their satisfaction in working with patients with chronic pain that indicated they were learning more. So we had one item that said, it was on a Likert scale, so I usually have a new idea for working with my more challenging patients with chronic pain, and that the mean score went up every year. They had more ideas, and that's what we all want. That's what makes our job satisfying, is being able to help people, being able to make a difference, feeling like we have something to offer that works. So with that, Javier, do you have any final comments, or Heidi, or should we take some questions now?
Yeah, we could take questions.
Very good. Thank you all. This is Polly Kurtz again, and we would love to welcome anyone participating on the call to ask questions of our panelists today. You can do it a couple of different ways. You can either type it in the chat box or the question box, or if you would like to ask a question verbally and have a microphone on your computer or have joined by phone, I would be happy to unmute you. Just there's a little hand next to your name. You can click on that hand and I'll call on you, and you're able to do it that way. While we're waiting to see if there are any questions, I'll remind everyone that our CFHA annual conference in Charlotte this October 13th through 15th, entitled Celebrating the Many Faces and Places of Integration, is our registration for that conference, and the bulk of our program is now available on the CFHA website. Registration's open. We'd love to see you all there. I think Robin did a great job of highlighting one of the many tracks that we have this year. So we've got lots of opportunities, and it's a great opportunity to network and really join our community. So please check that out. And guys, presenters, I think you all may be off the hook with questions. I'm not seeing any questions come in or anyone raising their hands. I could be missing it. So are there any last comments from our panelists?
No, not for me.
Well,
Okay.
yeah.
All right.
Well, it's been great. Again, thank you, Polly. Thank you, Heidi. Thank you, Javier, for all your work and for all you do to promote integrated good health care to your patients.
Wonderful. Thank you.
Yep. All right. Thank you all.
Thank you all. And as a reminder, the recording of this will be up on our website, and we will make the slide deck available. This was a wonderful webinar, and thanks to our panelists. Bye, everyone.